You hear me well? Great. So very nice venue. Thank you, Vicky, for setting the frame. So my name is David Montano. I'm the portfolio manager for clinician productivity solutions at Solventum. Very excited to be with you today. I have the privilege to be joined on stage by Dr. Kate Musgrave and Dr. Chris Plummer from Newcastle Hospitals to share with you the results of the implementation of a novel digital application that we call Follow-up Finder for VTE. VTE stands for venous thromboembolism. It's the result of a collaboration that we started with Newcastle Hospitals about 2 or 3 years ago with the purpose of advancing or optimizing the workflow for thrombosis diagnostics management. This is the clicker, I assume. Yeah. Great. We have kind of a busy agenda today. We're not going to go into all the details of what we're going to tell you. It's just the story of our journey from the identification of the challenges and pain points in thrombosis diagnosis workflow, all the way through the implementation of the solution and ultimately the results and the impact that we managed to achieve. But just a quick word about Solventum, because I think it's not a name that you are very familiar with, at least not yet. Solventum is a new company. It's the result of the separation of 3M healthcare business into an independent standalone company. So we see ourselves as a new organization, but with a very long legacy of innovation in healthcare, with an aspirational mission of enabling better, smarter, safer healthcare to improve lives, and with a set of values that include put people first, advance together, which I think are perfectly embodied in what we are going to show you today. At a glance, more than 70 years of history of innovation in healthcare, more than 7,300 patents issued, more than 20,000 employees all around the world. It's a very diversified organization. We have three main business categories. Of course, I don't have the time to go through all the details, but I encourage you to visit our website, to pass by our stand later today, learn about what we're doing, all the exciting things that we're doing in diagnostics that goes beyond these software applications, but also other applications that we would be happy to discuss with you. Without further ado, leave you the stage.
So my name's Kate. I'm a consultant hematologist and the thrombosis lead at Newcastle Trusts, and I'm just going to tell you what our problem was. VTE, or blood clots, are a huge public health problem. So what we mean by that are something you might have heard of as deep vein thrombosis, pulmonary embolism. These are things that kill people. And the people that survive have significant long-term morbidity. We're talking pain, swollen limbs. It affects their ability to work, it affects any age, and the treatment is long-term anticoagulation, or what's colloquially known as blood thinners. And they themselves can put restrictions on a person's life, and it's not uncommon for patients to need them long-term. What's even more of a problem for me in particular are hospital-associated blood clots. So these are PATs, or blood clots associated with a stay in hospital. And 50 to 60% of all blood clots are due to being in a hospital. So as a hospital consultant, this is something that really worries me. And they are the leading cause of preventable patient death. And it's something that I feel, not just nationally, but internationally, we need to take more seriously. And we've been limited by this because whereas if you look at something like infection control or MRSA, C. diff, things you might have heard of that we can monitor, it's actually very hard to keep an eye on all the blood clots that we see because there's so many of them, and figuring out which of them are associated with a stay in hospital. And the problem we had in Newcastle is there's 900 scans performed every single day that can potentially show a blood clot. And if you ask a human to go through those, whether that's radiology or that's a nurse, that adds a lot of extra time. It doesn't guarantee that you find all of them. And once you've spent all the time doing it, you can't really do anything with that data. And it's basically impossible. So when I started in the thrombosis service, like many hospitals around the country, we were spending nursing time every morning, desperately trying to find all the people that had had a new blood clot. And it just wasn't possible. We were finding as many as we can, and then we just had to stop and we had to go and actually start treating the patients, which is what we were there for. So when we went to Solventum, we said, we have all the data, we have all the information we need, and we are unable to use it. I'll pass on to you, David.
Thank you. So exactly how did we use the data? What mechanisms did we put in place to address the problem that Kate's team was facing? So Fallout Finder is the articulation of several capabilities. In a nutshell, at its core, there's an algorithm of natural language understanding that identifies and surfaces clinically relevant findings from a clinical narrative. So in this particular use case, the clinically relevant findings is verbiage associated with thrombosis, and the narrative is radiology reports. So we automate the process of surfacing those findings. We integrate with the systems within Newcastle hospitals, in both directions, both for getting access to those radiology reports directly from the PACS reporting system and the integration engines that were already available, and to deliver those results back into an environment that the nurses were already used to working in. So that would be the electronic medical record that Newcastle Hospital uses. So these messages will be delivered in a way that they can be picked up by the electronic medical record and actionable upon, to create a work list that the nurses can easily follow, so that the patients that are in it are sent to the next level of care in a timely fashion, therefore creating efficiencies and reducing the risks or patients not being appropriately identified and managed. I would also like to take a minute to talk about the innovation in terms of how we're working together. It's not only about the technology, but also how Newcastle Hospitals and Solventum put together a very interesting model for collaboration to develop this solution. We established a regular touch point so that we constantly get access to feedback from the nurses that are using the system, so that we continuously improve the algorithm, fine-tune it to reduce the risk of having false positives or false negatives results, and getting high levels of accuracy that we're gonna go into in a bit. It's also a first of many kinds kind of customized solution. It's the first time that as an organization we deploy this outside of the US. It's the first time that we deploy it in a Cerner Millennium environment, and it's the first time that we deploy it for this particular use case of thrombosis. So there were many hiccups along the way. It required us to work in an environment of trust. The learning curve was definitely steep, and there were many things that we needed to start and restart again and redefine along the way. But fortunately, with Newcastle Hospitals, we found an environment in which we were able to have that freedom to explore, to test different things, and ultimately to deliver what I think are very exciting results.
Oh.
Thank you very much. I'm Chris Plum. I'm the CCO, so medical lead for digital in Newcastle Hospitals. And my job in some ways is to join up clinicians with problems with potential solutions. And that's what I think we've done here in a really innovative partnership. We have created something that neither of us could have done on our own. And what does it look like? And this is developed in Newcastle by our app support team, Sarah and Stephen and their colleagues. And instead of the thrombosis nurses coming in on a Monday morning and trying to trawl through hundreds of scan reports in packs, they come in and there's a list of 28, and they click here to go to the radiology report, click here to go to the patient treatment, click here to make a note, and click here to collect actionable data. So we are collecting in real time whether this was a thrombosis or not, whether it was a hospital-acquired thrombosis. And that's completely changed the dial in what we can do in terms of feedback to clinicians. And it's completely changed the way the culture around venous thromboembolism in the trust. And it's resulted in very significant improvements in what we can do. And I'll hand back to Kate to tell you about them.
So now I get to tell you the good things. So firstly, it works. It works incredibly well. So it's extremely sensitive. and we have various systems in place to check that it's not missing any, and it's brilliant. The number of false positives, we want it to be more sensitive than specific. So there are some false positives, but because of the way it integrates with our e-record, it's very easy to get them off the list. So it works brilliantly. And it's, as Chris said, there's been a real culture shift in how we manage and how we prevent venous thromboembolism. So first of all, compared to how many clots we were finding before, there's been a 48% increase. Our nurses can spend half an hour now reviewing everyone on the list and giving help when needed. And when we've looked at that, we've realised that a third of our patients are not on the most optimal care for a new blood clot. And the thrombosis team, through our nurse specialists, can reach out and say, you know what, you need that anticoagulant. This person needs to go to vascular, they need a thrombectomy. And things are happening much, much faster. And teams know about us and they're getting referred to our service and they're getting better help later on. One of the things I'm most proud of, though, is we're the first trust that I'm aware of, even internationally, that can in real time say, these are how many hospital-acquired thromboses we have every day. This is how many we have. And we can divide them into saying, okay, we know that as a trust, we are a busy trust, we have a lot of trauma, we have a lot of cancer patients. We can't prevent every blood clot. But what we can say now is, this is the percentage of people that we have done our absolute best to prevent their blood clot. They have had the optimal VT prevention. And anybody where we look at it and we say, this could have been better, it goes straight back to the clinical boards, it's looked at weekly, we report on it quarterly, and instead of having a blame culture of, oh, somebody's had a blood clot, it's, well, actually, what can we do with our system to make this better? How can we reduce it? And so we have cut down the number of people that have suboptimal VT prevention by 53% in 1 year because we have this kind of data and because we have a way of surveilling our system. Also, we freed up 2 hours of nurse specialist time every single day, which is huge and made a massive difference. And they now have regular clinics of their own. They do nurse-led clinics. They're helping patients. They now will see everyone who's had a blood clot in our trust within 3 weeks to check they know exactly what's going on. They understand the blood clot. They understand the treatment. There's no questions. So they're getting that extra support before the medical review later. And I'm really passionate about recruiting to thrombosis clinical trials. They're really hard to recruit to because you need to find somebody with a blood clot and you need to recruit them usually within 5 days if you're lucky, if not shorter. And it's almost impossible. And this is an international problem. So we've got 2 clinical trials running at the moment that internationally aim to get over 1,000 people in the first year and got 83. That's how difficult it is. And this is not an unknown thing. And across the UK, it's a big problem to try and open commercial thrombosis trials. We've increased our finding of eligible people by 100% by using this list. It's an absolute game changer for us.
Now log on to our patient record and automatically we have what is called a VTE list. So in real time, if a patient goes for a scan and is diagnosed with a blood clot, it will automatically add to the list in real time. Don't have to log on to PACS, we don't have the Excel sheet anymore. We all just have everything on e-record. So the patient is there. We can click onto their details straight away. We can add a note straight away from this list that's been made. In fact, it's all in one place. That makes it much more efficient for us. We know about all the blood clots now that are found on scans. And I said the delayed ones are the huge ones for us that aren't missed anymore. So it makes our journey for the patient much easier, their journey, and so much more patient focused in terms of safety.
We decided we couldn't say it better than Robin, so that's great. Thanks to her. The thrombosis nurses, unfortunately, looking after people with thrombosis and can't be here today. So, just to finish off, why did this has clearly worked for us? Why did it work? What are the key factors to make this work? And I think we're very focused on this because we want to think about what we're going to do next. So we had lots of data. We had lots of high quality scan results, radiology reports. But it was in too big a haystack for the nurses to look through to find the very important time-limited needles there, the patients who would really benefit. And there were quite a lot of those. As Kate has said, 30%, we've actually changed management of those people. We also knew what to do. We had an intervention that was going to change patient outcomes, changing their anticoagulation, putting them on anticoagulation when they weren't on it before. And we had a highly motivated clinical workforce who wanted to make that happen. They just couldn't see the wood for the trees. And then we've derived analytics from it that's changed the culture, changed the dial absolutely within our trust in terms of managing venous thromboembolism. So what's our vision? How does this work for us going forwards? For us, I think personally and professionally, it's been a great collaboration between the problem and the problem solver. And I think we've got great plans for taking that forwards. For me, absolutely aligns with the shift from analog to digital. We've got a mass of data, unstructured data, we just can't get actionable insights from. And that's where AI, I think even the AI that we have now in clinical practice absolutely can help us get that actionable information. And what we're doing now, what other problems do we have that fit those success criteria? Where do we go next with this? Because firstly, we're not the only hospital in the world with a VTE problem, but there are lots of other problems where there's too much data for the clinicians to work through quickly enough and efficiently enough to get the best patient outcomes. So we'll stop there and we're happy to answer questions. Thank you very much.
So because the guys did their presentation perfectly to time, they have 5 minutes for questions.
Brilliant, no questions.
Is there a way for the system to do the next step, which is to integrate with electronic health records and look at things like EGFR and drug interactions, things that subsequently guide clinical management, not to take away anything from the proposed nurses, but actually something to help the clinicians to help with management?
Yes, and I think that there's a huge opportunity for EPRs doing more than they do at the moment, which is just hoovering up data. What it needs to do, and everybody knows this, is to aggregate that data and give us back insights. The regulatory requirements around that are absolutely huge, entirely appropriately. So that's a work in progress. This is how do we solve the clear and present danger, if you like, of having the data but not being able to access it fast enough, efficiently enough to get the patient outcomes. So I appreciate we're solving a little bit of the big jigsaw, but it's a really important bit.
Thanks, guys. What a fabulous presentation and a great example of the controlled use of AI. Just brilliant. Very often we see clever tools for little specific problems. This is not a small specific problem. This is something that's a big issue across the globe, actually. But what's the diffusion plan for England? How are we going to get this out there?
We're working on that. We're working on that collaborative model that I was talking about is going to extend to see how we can work together between both organizations to scale this up. I shouldn't say too much about that, but there's gonna be news to come on that front.
But it'd be fair to say that Kate's had some inquiries from friends. Would that be fair to say?
Yes, many Clotty friends are very interested.
Hi, thanks. Really interesting talk. I just wondered about how you set up the collaboration, because that can't be easy with an NHS group. So how did you find Solventum and how easy was it to make that happen?
So maybe if I comment first and then David can correct me. So we had a relationship with Solventum around voice recognition, our front-end voice recognition system. And they came to us with a proposition to say, we've got all these other tools. What do you think? Can we work together on some of them? And this is the one that we chose. And Kate's was the project that we chose first because of all the success factors that we've just gone through. And it's really worked. So we're keen to do it again and more and, allow this technology to work for other NHS organisations and more broadly, but also think, what other problems, what other haystacks do we have that we can fix with this kind of solution?
Brilliant, thank you.
Just thank Chris and Katie and David. Thank you very much.